Welcome to the Injury Report here on ESPN760.com. I am John Martin, and I'm here with Dr. Jonathan Cutler of the South Florida Foot and Ankle Centers, WCFoot.com. Been in the area for a long, long time doing great things. How are you, Doc?
I am doing great, J. Mar. Looking forward. I'm glad that you could be here today. I'm excited to have you. I'm excited for our guest. We got a lot of good things to talk about. This is, I think, our fourth show, and I think this could be the best and better than all of them.
I hope it is. Did you want to go ahead and introduce the guest?
I'd love to. I have the pleasure of introducing Dr. Jeffrey Kugler. Dr. Jeffrey Kugler has been in the area for approximately 23 years in South Florida, helping people all throughout Palm Beach County. Dr. Kugler was the lead orthopedic trauma surgeon at Delray Medical Center. He's been on staff at numerous hospitals, including a list of Palms West, JFK, Wellington, Bethesda, Delray Beach. The list goes on. I mean, this man he's a workhorse. He doesn't stop doing all different types of traumatic injuries throughout the upper and lower extremity, specifying mostly the lower extremity, with all different type of athletes, young kids. But also Dr. Kugler has interest in helping people who've been in sports their whole life. People like you and me, that weekend warrior who after 30 or 40 years has that knee that's been worn away or that hip that's been worn away and needs that implant. And Dr. Kugler has a tremendous amount of experience, probably more so than most people in the United States in fixing those. On a brief introduction, Dr. Kugler is from New York, where he then went to college at Vanderbilt University, played golf at Vanderbilt University, and in his younger days used to be a scratch golfer. I haven't played with Dr. Kugler in 15 years, so I don't know what it's gone to. He's recently taken up hockey as his main sport, so I'm really not sure how his golf game is going. But after Vanderbilt, went to medical school at University of Florida, so he is like a gator for all these gators out here. And then had the luxury of doing his residency at Barnes Hospital in St. Louis, Washington University in St. Louis, which at that time, I know I was there, was the #2 medical school in the country.
Wow.
So has a tremendous amount of experience. Really excited to have him here today to talk about some of the things that we can go over today. So on a personal note, I've known Dr. Kugler personally since he got into town. He helped me when I injured my knee, and I was one of his first patients, and got me better right away. And since then we formed a friendship. But we're here talking about sports medicine today, and Dr. Kugler, it's frustrating for me to say this, J. Mart, Dr. Kugler is the one person who could probably beat me in every sport. I can usually beat someone in one thing, whether it be tennis, basketball, ping pong, pool. Dr. Kugler is the type of athlete who could pick up a sport within 10 minutes and become proficient at it.
Wow.
Example, and he took up hockey, I think 7 or 8 years ago for the first time. He took up hockey and is now playing competitively in the various local leagues in town. So it pains me to say that I am second, but so that's the introduction of Dr. Kugler.
Wow, Doc, what do you think about that glowing introduction there?
Well, I could definitely beat him in almost every sport, so I would agree with that.
Well, let's get into what you do. Dr. Cutler talked about how you do deal with let's say the weekend warrior that's been playing sports forever. When you deal with somebody that's been playing sports for 30, 40 years, what are the most common kinds of injuries that you see and deal with?
Well, there are two subsets. One is the lower extremity injuries, and injuries based on old meniscus tears or ligamentous injuries that may or may not have been diagnosed in high school. We see a lot of knee injuries, and over 30 years of wear and tear, we see a lot of arthritic changes, some of which are treated with conservative measures, some have new arthroscopic treatments, and many of which go on to a total knee replacement. We also see a lot of upper extremity injury, especially in the shoulder. You see a lot of rotator cuff injuries and labral tears from wear and tear on the rotator cuff and from instability patterns from people who had dislocations years ago, and gradually the shoulder deteriorates as well. So once again, many are treated non-operatively, many which go on to arthroscopic shoulder procedures.
I know when I'm thinking about doctors, one thing that really means a lot to me is when I know that other doctors have gone to said doctor. Dr. Cutler here just said that you treated his knee. How like give us an example of how that goes, what that process is like when you're treating a knee of a guy that's played for so long. You know what I mean? That's been an athlete for, what, 30 years or whatever.
Well, I think you're exaggerating Dr. Cutler's skills if you call him an athlete.
Okay.
That may be a slight exaggeration, but in general, what you'll see is that they'll have pain. They'll have pain predominantly with weight bearing. They'll have clicking and popping on the knee. They frequently have degenerative meniscus tears, which cause clicking, popping, locking, and swelling. And the problem is people have pain every time they play. And I play in an ice hockey league now, as John mentioned. My oldest son started playing hockey about 6-7 years ago, and I started for the first time. And I see these guys all the time. All my teammates are in my office because every time they skate, they have pain, they swell. And frequently they're treated with injections and bracing, and sometimes we do arthroscopic surgery. And I just did a knee replacement on one of my old teammates. So he's a little older than I am, but his knee just wore out, and he had an injury about 25 years ago, had an old ACL reconstruction done with the old open technique, and it just didn't work very well. And his knee just deteriorated. He was in his mid-50s, and he just couldn't walk, so
Wow.
he ended up with a total knee replacement.
On that note, Dr. Kugler, what are some of the things that have changed? You've been around, you're no youngster anymore. You've been
No kidding about that.
You've been around for 25 years, and your training, you probably started 5 years, so you've seen about 30 years of different treatments that have been involved with the knee. We're talking about that implant that you would do. Where have the advances in medicine come to help you treat that arthritic knee?
Well, the arthritic knee has been revolutionized by the different implants, and the problem with the implants years ago is the bearing surface. It's the poly and the metal and the articulation and the debris that's created, and it just doesn't last forever.
Now understand, Dr. Kugler, that you're talking way beyond. I'm just an ankle and foot guy. Talk to me about what you mean the different surfaces.
Well, in a knee replacement, you have a metal femur and a tibia that has a plastic insert on the top of it, and that is the new bearing surface. And over time, that wears out. And the problem with implants placed 20, 25 years ago, they only lasted for 10 to 12 years, such that they had to be redone. And if you were 52 when you had it done, well, when you were 65, you had to have it redone, and then you were 75, you had to have it redone, and each time you redo it, you lose bone stock, and you lose tissue, and the muscle's traumatized, and you have a less predictable result. So the newer implants have a surface that's, at least in the laboratory, designed to last for 30 years. So that's a big difference compared to the previous longevity, which is more in the 10 to 12 year range.
Wow. And, I've been reading about some of the controversies that are going on right now. It seems to be, we can't turn on a radio station, I don't think this one, J-Mar, but we can't turn on a radio station or a TV station without hearing some lawyer saying, if you had this done or that done, or there's a big controversy, what's going on as far as these implants go. I'm sure people are scared. What are some of the negative implants, or you must be familiar with some of those things. What are some of the negative things that are being talked about, and why that implant is negative versus a different type of implant?
Well, in the knee, all the implants are a metal on plastic articulation. So there really is not a big controversy in the knee. In the hip, there's 3 different articulations. There's the poly, which is similar to the knee. There's a ceramic, and then there's the metal. And the metal on metal has the problem of metallic debris, and that's the one that people have been talking about recently, the big controversy on the metal on metal implants. And there's a couple problems with the metal on metal. One is where the ball articulates with the cup. That's one type of metal on metal debris. And the second is the module, meaning the component that goes in your femur can be 1 piece or 2 pieces. And certainly implants that have a 2-piece, you have a device that fits in that unfortunately didn't fit as well as probably should have or could have. And that created a lot of debris as well. So what people have, they have pain and swelling. They develop what's called a synovitis, which is an inflammation of their hip joint from this metallic debris, and the metal ions are actually leaking into their circulation. And
So that's the debris from from the resistance or the friction of the metal hitting against metal. You're saying that can go into their joint capsules and possibly further places in their body?
correct, it goes into their capsule and then it gets absorbed into the circulation. And if you test patients, their chromium and cobalt levels will be sometimes 90 or 100 times what the normal levels are.
Wow.
And it's thought that that has some carcinogenic properties. So that now all these people have to have their hips revised to get the metal and metal articulation changed.
My dad actually had hip replacement probably 10 years ago at this point, but they said it was a titanium ball and it was in there that had, it was full of holes and that the bone would eventually grow through it. Is that what we're talking about here, or am I talking about something totally different?
Well, the titanium is a type of metal.
Right.
Titanium has a very compatible elasticity to bone. Bone grows into the prosthesis very readily. So it's an excellent material for the stem. But because it's very soft, it's a terrible material for the bearing surface. Years ago, they thought we'd make the femoral components of a total knee replacement out of titanium, and that turned out to be a disaster because the metal was too soft. And it created all this sludge of debris, such that when you go to revise it, they have this just black, tarry debris everywhere. And you have to take hours, literally, to pick out all this debris and then revise it. So titanium is great for the ingrowth, as you mentioned. It's not great for the bearing surface because it's too soft.
So, knowing that, like, what is my dad gonna have to think about going forward? Is it something he's gonna have to address in a couple of years? If it was 10 years ago, like, what should he be thinking about as somebody that has that in their body?
Well, if he had a femoral head made of titanium, then that's probably going to be a problem. If he had a head made of chrome cobalt and just a titanium stem, he's probably going to be fine.
Are they taking these metal-on-metal implants out prophylactically before there are even problems because the chance of such severe problems exist?
Well, I wouldn't say prophylactically. I would test the patient first. I would test their x-rays to see if they have any loosening or problems. You get a CAT scan or an MRI to see if there's any what's called pseudotumors or debris, and then you check their serum levels. And if their serum levels are 90, 100 times normal, then I would recommend taking the implant out because you're running the risk of developing cancer from the metallic debris.
Wow, J-Mar, I mean, I'm telling you, I'm pretty much up on a lot of the stuff, and I got to tell you, I'm glad we're talking about this, because I did not know the severity of the metal-on-metal. I knew it was extremely controversial, but I didn't know the severity of it to this extent. So knowing metal-on-metal is not the way we want to go in the future, what companies, what are some of the different properties that you're using, some of the companies that you're using, that you feel are going to give you the best results for some of these knees or hips?
Well, one of the companies has a articulating surface called Oxinium, which has the advantages of the ceramic, which has a finer composition, so it has less debris, but it's stronger in that it doesn't have the fragility and the potential of breakage. Ceramics are great. The problem is when they break, they explode like a glass. It goes into a million pieces. And that was a big problem with some of the implants years ago, was the head would actually break. And that obviously was a big problem. So they've kind of circumvented the problem by getting the best of both worlds. You have better bearing surfaces with a stronger surface with this Oxinium implant.
J-Mar, Dr. Kugler, we won't mention his name, did a hip on a prominent NBA player, played, was on the NCAA final team back in the 80s.
Winning team.
Winning team, won the NCAA tournament. Dr. Kugler performed a hip implant on this gentleman. And so the question I have for you, Dr. Kugler, is, someone who, and he's a relatively young guy, I mean, he's late 40s, someone in his late 40s undergoing a hip implant, what do you advise him as far as his future of what sports can he play, what are his limitations, what can he do having had that implant?
Well, that's a really good question, and the ideal age range for an arthroplasty or an implant is somewhere in the 65 to 70-year-old range, such that I tell the patients, before you do this activity, think about it, would a 70-year-old man do that? And if the answer is yes, then it's probably okay. And if the answer is no, you probably shouldn't do it if you want your prosthesis to last as long as possible. So Bo Jackson was a classic example. He had avascular necrosis from a football injury, which was a tragedy, and he went back, had his hip replaced after he developed avascular necrosis, and went back and played professional baseball, which was an amazing accomplishment. The problem was he's a 230-pound guy running full speed, sliding around the outfield, and his hip wore out after about 5 years and had to have it redone.
Wow.
And that's the big problem. So yes, you can do great things with it, but should you do that is the question. And obviously the answer is no. Professional baseball is not an ideal post-operative activity after a hip replacement.
But what is? I mean, living here, let's talk about the, in our population down here, living in South Florida, you have that younger population who's undergoing these implants. You have that mid-50 person who likes playing golf, who likes playing tennis, who
I appreciate you saying that mid-50s is young. I appreciate that.
Hey, listen, I'm there with you, Dave. So, who likes jogging and working out in the gym? What are you going to tell that person as far as his limitations?
Well, jogging would not be a good activity, but you can be very active. You can play tennis, you can play golf, you can swim, you can bike, you can ski. High impact axial load, meaning running up and down on it, is just not good for the implant. So those activities you want to avoid, but you can work out and you can be active and you can play sports. And that's one of the reasons we actually do the implant in the first place, so people can go back to do those activities. But once again, think, would a 70-year-old man or a 70-year-old woman do that activity? Jogging 3 or 4 miles, probably not such a great idea, but being active is a good idea.
Well, you talked about, you brought up the example of Bo Jackson and coming back and playing professional baseball. What is the negative, if you decide to do that, assuming that you have the money to get the surgeries done by the best doctors, what's the downside to wearing the hip out and having to get it done again? I mean, obviously you have to go through another surgical procedure, but does that affect you long term? Does it degenerate? Do you get worse and worse the more they have to work on it?
Yeah, absolutely. The big problem is every time you put an implant in and take it out, you have to cut through the soft tissue, you damage the muscle and soft tissue to a certain extent, and the biggest problem is you lose bone every time you do that. You have to ream the bone away. You have to ream the acetabulum or the pelvis part. So each time you do a revision hip, you're losing more bone. And when you start really young, it's a big problem because you run out of bone. You literally run out of bone, and you have to use some very special fancy prostheses which have their own sets of issues. So you have the risk of anesthesia, surgery, infection, and wound problems. Plus, you run out of bone. And that's a big problem with revision joints, the multiple revision joints.
So when you advise people to think of themselves and would a 70-year-old do this, I mean, that's vital, that you take care of yourself after that and you make sure that you're not putting too much strain on it because of things like that.
Right, if you want it to last for as long as possible. And as you mentioned, we are doing these in much younger people. People today are much less tolerant of their pain and much less tolerant of their limitations, and they want to live full, active lives, and they're demanding truly demanding more aggressive treatment. And it's a great procedure, but you just have to be able to be aware of the limitations post-operatively.
Okay.
This is ESPN 760, the Injury Report with Jonathan Cutler and hosted by John Martin. We have the great pleasure of having Dr. Jeffrey Kluger here today. And we've talked a little bit about some hip injuries, arthritis. We're going to take a little break and come back and talk about a little ACLs when we come back after this break.
Welcome back to the Injury Report on ESPN760.com. I am John Martin, and I'm here with Dr. Jonathan Cutler of the South Florida Foot and Ankle Centers. You can check him out at WCFoot.com. as well as Dr. Jeffrey Kugler of the National Orthopedics and Neurosurgery. He is a board-certified orthopedic surgeon and adult reconstruction and total hip and knee joint replacement specialist. That is really tough to say.
Good job,
You did it very
Jay.
well.
Good job, Jamar.
But let's talk about the hip a little bit here. Have there been any new approaches to the hip replacement that we were discussing before?
Well, there has been, in the last maybe 2 years, we've come up with the anterior approach, which is the approach to the hip from the front. And years ago, we used to use that approach on kids and other type of procedures, but not to place an implant. And what's happened over the last few years is that there was a table design that really facilitates the placement of a hip replacement through this anterior approach, which has a lot of potential significant advantages of quicker rehab and less muscle damage, and it can be done under fluoroscopic or x-ray, so you can get it basically just about perfect each and every time. So there's a little extra training involved, and the table really facilitates your exposure and makes it such that it's a great way of doing a hip replacement. People do better, they do better faster, and you have more reproducible results. So that's the trend toward doing hip replacements. And probably about 80% of the patients would be candidates. There are a few contraindications based on bone stock and the pelvic anatomy, but the vast majority of patients are amenable to an anterior approach and can be done safely and effectively.
So Dr. Kugler, if, you know, what happens when someone's listening to us and their parent lives in Iowa and they're going to have the surgery and they say that their doctor wants to do the posterior approach? Are there negatives of doing that posterior approach now? Would you recommend them to get another opinion on an anterior approach, or a posterior approach could work quite well?
Well, the posterior approach is the way hip replacements have been done for 50 or 60 years. The vast majority, once again, do very, very well. There are some little issues of dislocation rates, sciatic nerve injury, muscle damage to the gluteus muscle. So there are some negatives to the posterior approach. And the anterior approach, while it has some slight increased blood loss and potential femoral nerve issues, it's a very viable approach that can be done. Not to say a posterior approach is a bad way of doing it. I still do probably a third of my cases through that approach because of a variety of issues related to previous incisions and bone quality. But the majority of primary first-time hip replacements can be done safely through an anterior approach with the advantages of reproducible results and equal leg lengths and less muscle damage. So it's an attractive approach for the majority of people undergoing hip replacement surgery.
So to sum it up as far as the hips are concerned, you know, some of the things that some of our listeners or their friends or family should be asking some of their orthopedic surgeons prior to a hip surgery is what type of material the doctor will be using, what approach he should be using. Are there any other questions that you think would be appropriate for that patient to be asking his doctor?
Well, the approach is really critical. The type of implant, whether it's cemented or non-cemented, is an important subject. And as we talked about previously, the bearing surface is really critical. And while there is some disadvantage to polyethylene, currently the high-dense cross-linked polyethylene has a very good track record. For younger, thinner patients, the ceramic on ceramic has a good track record. And I would try to avoid the metal on metal because it has the problems of the leakage of the metallic ions into the circulation. So I would try to stay far from that and use either ceramic or poly.
I think lastly, Jamar, you know, one of the subjects that's hot right now, again, this is a time-sensitive show where it's on the internet, is ACLs. You know,
Right.
We were watching the game and all of a sudden we're looking around to play, and 20 minutes before the game, the coach says he's not playing.
Right.
Had a hyperextension is what he called it, and then later came out and said it after the game because he didn't want to upset his players, that it was an ACL. It seems like the ACL is just one of these common things we're seeing more and more of in football,
Absolutely.
and in basketball, and it doesn't seem like anyone's getting hit. You know, they're playing a game and all of a sudden they just go down like air hit them.
Mm-hmm.
How does that happen, Dr. Kugler?
Well, the ACL is a very commonly injured ligament, and it's injured frequently from a hyperextension or a rotational type of mechanism, so it's not always getting hit. Certain percentage are, but Derrick Rose last year, injured, just landed on it. And Rondo just landed on it just wrong, and the ligament gave out. And guys are getting bigger and faster and stronger and putting more and more stress, and the ligament just can't withstand the stresses. And it's unfortunate because it's such a vital structure for an athlete who's going to play a sport that requires sudden deceleration or stopping or pivoting quickly. If you don't have your ACL, your knee is going to give out every time that happens, called a pivot shift. And you just can't play at a high level with that situation. So it's very prevalent, and fortunately the basic science and the surgical techniques have evolved over the last number of years so that people can recover and actually return, as Adrian Peterson did, in 5 or 6 months, and basically as good as he was before.
Why is that particular ligament more susceptible to injury than others? Or is that not correct?
Well, it's the medial collateral ligament is injured very frequently as well. The difference is the MCL, or medial collateral ligament, is treated non-operatively in general. It's injured, you brace, you rehab it, and in 5 or 6 weeks it's healed because it's outside of the joint, so it tends to heal. The ACL, which goes through the middle of your joint, does not heal. So there's no way to really repair it, and there's no way to play without it. So it has to be reconstructed. You have to put a graft of some material to substitute for your ACL. And unfortunately, because of the various properties, including the position and the nerve and the proprioception, which is the feeling of your body in space, you can't really reproduce exactly your ACL. You can put a graft in and you can make your knee stable, but it's not exactly the same as a normal ACL.
Now, why is it that, why would an ACL be more, like, what's the difference between men and women when it comes to ACL injuries?
Well, there are a couple differences. Number one is a training aspect. Guys start usually playing sports earlier and they have more muscular training than women, which is an issue. The second is that the anatomy is a little different. Women tend to have a little more knock-kneed appearance, or valgus appearance in the knee, and that contributes somewhat to their stress on the ligament. And also their notch, or the central part of the knee, is thinner, and it tends to impinge and create more ACL injuries with less stress, so that the stress that a woman places on her knee probably may not tear the ligament in a man. But in a woman, because of the factors we just mentioned, they don't have the protective muscle forces, and their anatomy is a little different, and their ACLs tear relatively easily compared to a man.
How can somebody, whether it's like Dr. Cutler and I, or the most elite athlete in the world, what kind of things can we do to avoid these knee injuries?
Well, you can strengthen the muscle around it. So a ligament is a static structure. You cannot make it stronger, but you can strengthen the muscle around it, you can protect it. You'll notice that many of the football players prophylactically wear braces, and the braces help prevent their knee from getting into very awkward positions, like RG3's knee was placed when he got hit originally, and you saw his knee flopping around. That was significant trauma. Had he had a brace, there would have been less displacement and potentially less injury to the knee in the first place.
Now, you brought up RG3, and he's interesting because he did have he got his ACL injury this year. He also in 2009 had an ACL injury on the same knee. Once you have that injury once, does it make you more susceptible in the future to the same thing?
If you continue with the same activities, as we mentioned, an ACL reconstruction is a great operation. It's been studied extensively. The grafts are strong, but it's not the same as a normal ACL. It's not exactly what the good Lord gave you. So yes, you're more susceptible than you were originally, and that's a big problem if you're going to keep going back to the same activities. So you're getting the same stress, and the ligament that you place, the graft, has a lower load to failure, and it's going to fail more easily than, in general, the original ACL that you were born with.
So theoretically, we'll use RG3 as an example. He gets the surgery in 2009. Should he have should he have been wearing a brace for the rest of his playing days just to get that, just a little bit of added protection?
Well, I always brace my patients for at least a year, but certainly in retrospect, and even looking prospectively, probably so, because you know he's going to get hit. That's the nature of pro football. It's a
Yeah.
violent game. He's going to get hit from the side. He's going to get hit, and he's going to stress that. And you know, he's got a $100 million or so contract. You want to protect your investment. The braces are light. They're well fitted. They're contoured individually, and I think probably in the future you'll see him wearing one for the rest of his career.
Actually, this is for both of you guys. From your perspective, is it different operating on a big-time athlete than it is like an average Joe from like, let's say, a mental perspective?
I mean, we've done several of them, and it's just, you know, we take concern in every patient that we have.
Sure.
So we're in the operating room, we have 5 cases scheduled that day, and that athlete probably is number 1 on the schedule. All right, he's the first one. But we take the same precautions that we do for anybody else. Obviously, there's a little bit more hand-holding for that type of person than for someone else. But actually, in the OR, nothing changes. It's the same routine, and that's why you go to someone like Dr. Kugler, who's been doing it for 25 years. Who it's a routine. Everything goes smoothly. He has it prepared. And for those indications where something comes up in the middle of surgery, as it will for anybody, he's been through it all and can handle it. So it's a good question, J. Mart. But as far as, you know, and on my perspective is, we've been doing this now for 30 years. So
Sure.
Our surgical technique really doesn't change, whether it's for, you know, someone we don't know, someone we do know, or, you know, I've even done something which is probably very controversial. I mean, I've done surgery on my own mother, which is something you really, you know, it's not supposed to be done. But the bottom line is, you know, it's my mother. No one's going to take better care of her than me.
Right.
And but I treated her the same way I did anyone else. So from my perspective, that's how I answer that question. I'd be interested in what Dr. Kugler says.
Well, I would agree as far as the preparation and the intraoperative techniques are the same. It's you take care of the injury. The stress level is a little higher, though, especially if it's a current professional athlete. The tolerances are just a lot lower than for a weekend warrior. And if you're doing a shoulder scope on a professional pitcher, there's just no margin at all for any issues. You have to make it perfect, or that 98-mile-an-hour fastball now becomes an 85-mile-an-hour fastball, which is no good.
Right.
So you know, there are some increased stresses to treating a current professional athlete, but the preparation and the technique is really the same.
Yeah, and actually, the reason I thought of that is because you think about like, let's say the Super Bowl. Like, these guys have played football all of their lives. You know, as you said, and they do the same things, same techniques. They've learned it all of their lives. But then this is the Super Bowl. You know, this is the biggest game. So yeah, you know, I would think that there would be some butterflies going into it. We did briefly mention Adrian Peterson, and he absolutely had a remarkable return from his ACL injury. From your perspective, is there a way to tell, like, either after the surgery or during the surgery, how a person is going to recover?
Well, if the surgery goes well, if you do the procedure, there's no associated meniscus pathology, you're just doing an ACL, and you put the graft in, and the graft's in the right place, then the patient's probably going to do pretty well. A lot of it depends on their ability to rehab and how hard they work after the rehabilitation is critical. The Adrian Peterson story is really interesting because I think it creates somewhat of a dangerous precedent where people think that, well, if I injure my ACL, I'll have my surgery and I'll be back in 6 months better than ever. And while that worked out for him, that's not really necessarily true for everyone. And surgery has complications. Tom Brady had an infection after his ACL 4 or 5 years ago, and while he's actually doing pretty well, you know, not everyone does well after infection. You can develop post-infectious arthritis and other problems, so the graft doesn't always last correctly. There are problems with ACL reconstructions, and you're not always, as I mentioned, back to 100%, so he's a great story and all that, but I think it's a dangerous precedent where people think now that's the way it goes for everyone, and that's really not necessarily the case.
Now, from the perspective of a weekend warrior, like I'm a regular guy, and I try to, as nice as you guys are, I try to avoid the doctor as much as I possibly can. When something happens, when you feel a little pain in your knee or something after playing hoops, like what are the warning signs that say, okay, you should go to a doctor and get it checked out?
Well, first of all, if you have significant swelling, that's usually a bad sign. If you're playing a ball and your knee blows up, that's usually not something good. If you have clicking, popping, if you have feeling of instability, I would get that checked out right away, because what could be a small problem initially can become a much bigger problem if it's neglected. Initially, if you just have some soreness, you can treat it with some anti-inflammatory medication, rest, and see how you do. But if there's a question, you should always get it checked out, because it can solve a small problem and save you from having a major problem down the road.
Yeah, I think it's all good advice we've heard today, Jamar. I think it's been, I'll tell you what, I've learned a lot. Just listening today, as far as especially the metal on metal issues, which I was unaware of. And I always knew there was a controversy. I didn't realize the extent of it, though.
Absolutely.
But, Dr. Cougar's been in town, like I said, 25 years or so, and has a tremendous amount of experience all throughout Palm Beach County. National Orthopedics, has a large group, which he's the senior member of, just brings to this table, to this county, to this whole area of health system, a great amount of knowledge, and has helped a lot of people in Palm Beach County over the last 20-some-odd years.
Sure. I mean, even just today, we've learned like what you should ask your doctor if you have a hip issue, if you're going to have a hip replacement, the best kinds of hip replacements, how to prevent ACL tears in the future. So I definitely think that we got a lot out of it, and hopefully we can be joined by Dr. Cougler again in the future. But for now, I guess we're wrapping it up.
And to reach Dr. Cougar, I think we can reach, how do we reach Dr. Cougar? I mean, some of our listeners want to see it. What's the best way for them to reach you? What's the number at National Orthopedics?
National Orthopedics, it's 561-296-1188, or you can reach us on the email at the jlkphysician@aol.com.
Okay, I think it's been great. And Jamar, I want to tell you, you did a phenomenal job. You came in, subbed in there last minute, and Steve's somewhere in the Super Bowl right now, eating some oysters, or I don't know what he's doing. But I'm telling you, you did a phenomenal job. Really glad you were here today.
Thank you so much, Doc. And you guys have been listening to Injury Report on ESPN760.com.